Kidney diseases can be complex, multi-system, and sometimes rapidly progressive. In a subset of these conditions, therapeutic apheresis plays a critical role, not just in managing symptoms but in preserving renal function and preventing irreversible damage. Let's explore how and when this life-saving intervention is to be used in nephrology. Therapeutic apheresis in primary kidney disease. First is focused segmental glomerulosclerosis or FSGS. It is a challenging glomerular disease that often leads to nephrotic syndrome and progressive kidney failure. In certain aggressive or treatment resistant cases, therapeutic apheresis may play a critical role. But how does removing plasma help the kidney? The key lies in the suspected presence of the circulating permeable factor. It is an unidentified protein in the blood that increases the glomerular permeability, leading to massive proteinuria. Therapeutic plasma exchange help by removing this circulating factor, reducing glomerular damage and potentially inducing remission. So what are the clinical indication for this? So first is your post-renal transplant recurrence of FSGS, which occurs in 30 to 50% of the cases, and TPE is often initiated immediately after recurrence is detected. Second is steroid resistant or treatment resistant primary FSGS, which is used as adjunct to the immunosuppressant like rituximab or calcineurin inhibitors. Third, in the condition where there is rapidly progressive nephrotic syndrome in children or adults, especially when biopsy suggests collapsing FSGS or immune mediated recurrence. Next is membranous nephropathy. Membranous nephropathy is the one most of the common cause of nephrotic syndrome in adults. It is an autoimmune condition where antibodies target podocyte antigen, most notably the PLA2R receptor. While immunosuppressants remain the mainstay of the treatment, in certain refractory or life-threatening conditions, therapeutic apheresis, especially plasma exchange, can offer additional benefit. So the pathophysiology of this disease is that the central mechanism is primary membranous nephropathy, involves circulating autoantibodies against PLA2R or THSD7A. These immune complexes deposit in the subepithelial space, damaging the glomerular basement membrane and leading to massive proteinuria. In this context, TPE or immunoadsorption can help by directly removing the pathogenic antibodies from circulation and potentially reducing the immune-mediated glomerular injury. Goodpasture syndrome, also known as anti-GBM disease. It is rare but life-threatening autoimmune disorder where circulating antibodies attack the glomerular and alveolar basement membranes. If not treated promptly, it can lead to rapidly progressive glomerulonephritis, pulmonary hemorrhage, and irreversible renal failure. The pathophysiology of this disease that it is caused by autoantibodies targeting the non-collagenous domain of the alpha 3 chain of type 4 collagen, which is found both in kidney and lungs. These anti-GBM antibodies cause complement activation, inflammation, and capillary destruction, leading to hematuria, proteinuria, and sometimes life-threatening pulmonary bleeding. The role of apheresis is the cornerstone of the treatment because it physically removes the circulating anti-GBM antibodies. It reduces ongoing immune injury to glomeruli and alveoli, and it works rapidly, which is vital in the fulminant diseases. The treatment protocol includes your TPE and immunoadsorption method, which can be done daily or alternate days, and it is category 1 indication as per the ASFA guidelines. Next is anti-neutrophil cytoplasmic antibodies, ANCA-associated vasculitis. So these are small vessel vasculitis that cause the rapidly progressive glomerulonephritis and life-threatening pulmonary hemorrhage. So while the immunosuppressants are the mainstay of the treatment, plasma exchange or therapeutic apheresis may be used in severe cases, but when it is exactly indicated. So that answer is in the pathology of the disease. So in ANCA, the primary anti-PR3 or anti-MPO activate neutrophil, which lead to inflammation and the destruction of small blood vessels, particularly in kidney and lungs. So this can result in RPGN, that is rapidly progressive glomerulonephritis, hematuria, rising creatinine, and even pulmonary capillaries with the hemorrhage. So role of TPE, it's that it will remove the circulating ANCA antibodies, cytokine and inflammatory mediator, which aim to rapidly reduce the immune attack on the vessel and especially on the glomeruli and the alveoli. So according to the ASFA classification, it is category 1, but now it is downgraded to category 2 based on the Pexivas trial 2020, which showed no mortality or long-term kidney benefit in most ANCA patients, but may still be helpful in pulmonary hemorrhage and dialysis-dependent cases. Plasma exchange in ANCA-associated vasculitis based on the KDIGO guidelines, which states that when there is severe renal involvement, that is the serum creatinine more than 5.7 mg by dl, or there is rapidly progressive glomerulonephritis with crescent formation, or there is life-threatening pulmonary hemorrhage like hemoptysis, hypoxia, or diffuse alveolar hemorrhage on imaging, and refracting or relapsing AV despite standard therapy. So there are various guidelines which states the role of plasma exchange in ANCA-associated vasculitis. So accordingly, we will advise our patient to undergo the plasma exchange. Next is TMA, thrombotic microangiopathy. It's a pathological process characterized by microvascular thrombosis, thrombocytopenia, and microangiopathic hemolytic anemia. It can lead to rapid organ failure, especially in the kidney, brain, and heart. Therapeutic plasma exchange is the first-line treatment in several types of TMA, most notably in the thrombotic thrombocytopenic purpura or TTP, where it has transformed outcome from fatal to survival. The core pathology of the TMA, it is not a single disease, it is a pattern of injury. The underlying cause determine the treatment. The key features are thrombocytopenia, hemolytic anemia with schistocytes, elevated LDH and low haptoglobin levels, organ dysfunction, often renal, neurologic, or cardiac. Major types of TMA are TTP and HUS. So in TTP, it is category 1, whereas in atypical hemolytic uremic syndrome, which is caused by the complement dysregulation, it is ASFA category 3. In TTP, it is caused by severe ADAMTS13 deficiency. It can be autoimmune or congenital, lead to accumulation of large von Willebrand multimers, that is platelet-rich microthrombi formation. And PEX remove these anti-ADAMTS13 antibodies and replenish the enzyme. With this, steroid capalizumab or rituximab can be used. Whereas in hemolytic uremic syndrome, which is caused by the complement dysregulation, it can be genetic or acquired. PEX used if diagnosis is unclear or isolizumab is unavailable. In typical HUS, which is usually post diarrhea because it is caused by the E. coli O157 is to 7 H. The plasma exchange is not recommended and it is managed by the supportive care. In secondary TMA, which occur because of drug malignancy, SLE, pregnancy, and transplant, plasma exchange can be considered in the selected cases, whereas there is limited evidence and the ASFA category given to us is 3 or 4. SLE, systemic lupus erythematosus. It's a complex autoimmune disease that can affect virtually any organ. with flares that range from mild to life-threatening. While most patients respond to immunosuppressive therapy, therapeutic apheresis, especially plasma exchange, may be used in severe or refractory cases, particularly when the disease becomes life-threatening. So, when is apheresis considered in SLE? So TP is not the first line, but can be used if the disease is severe, rapidly progressive lupus nephritis, when renal function declines rapidly despite immunosuppression. Secondly, it can be used when there is neuropsychiatric lupus, that means in cases of severe CNS involvement like seizure, psychosis, or coma. Third, when lupus with thrombotic microangiopathy, especially when the features of TTP is present, or catastrophic SLE, when there is life-threatening multi-organ failure associated with high antibodies titers. Another is the drug-resistant or fulminant lupus flare, when traditional therapies like steroids or immunosuppressant fail. How does it work? It removes the autoantibodies, immune complexes, cryoglobulins, and inflammatory mediators. It interrupts the immune system overactivation and provides a therapeutic reset while other treatments begin to work. So the treatment protocol is the 5 to 7 exchanges over 10 to 14 days, and according to the ASFA guideline, it is considered as type 3 category. Therapeutic apheresis in nephrology is not for every patient, but in right condition at right time, it can protect nephrons, prevent dialysis, and even save a life. Stay with Transfusion Vitals for more such episodes.